Physical therapy interventions and outcomes for a patient following hospitalization for viral gastroenteritis and resulting hospital-acquired pneumonia. Gastroenteritis is an inflammation of the gastrointestinal tract, including the stomach and the intestines, and is a major cause of illness in the United States. It is a significant cause of hospitalizations and deaths every year, especially in the elderly population. The purpose of the case report was to describe the interventions and outcomes for a patient undergoing physical therapy after a hospitalization for viral gastroenteritis using the International Classification of Functioning, Disability, and Health as the theoretical framework.
Patient AH is an elderly woman with chronic lung and cardiac disease admitted to the ICU following a stroke. On day 6, AH developed a productive cough, decreased air entry bilaterally, and lethargy. Her O2 sat was 87% on 15 liters by face mask. She was febrile, short of breath, and her blood pressure had dropped. Her white count was elevated, and a chest x-ray showed a new infiltrate. Sputum and blood samples were sent, and AH was diagnosed with hospital-acquired pneumonia, or HAP. HAP is the second most common hospital-acquired infection and occurs anywhere in the hospital. In the ICU, intubated patients develop ventilator-associated pneumonia, or VAP. HAP is defined as a pneumonia that develops more than 48 hours after admission, while a diagnosis of VAP requires patients to have been mechanically ventilated for more than 48 hours at the time of infection onset. Like all pneumonia syndromes, the diagnosis is based on the appropriate constellation of clinical signs and symptoms, and can mimic other syndromes like heart failure or pulmonary embolism. A scoring tool such as the Clinical Pulmonary Infection Score, CPIS, can aid in the diagnosis of HAP or VAP, and a score greater than 6 correlates with the presence of high bacterial counts in the lungs. It can be used to risk stratify patients and to guide both starting and stopping antibiotics. Once appropriate respiratory samples have been sent for culture, prompt initiation of appropriate empiric antibiotics is essential for good patient outcomes. The core bugs in HAP or VAP are the usual respiratory culprits: strep pneumo and H. flu, plus Staph aureus, and some gram-negative bugs like E. coli, Enterobacter species, Klebsiella species, and Proteus. To identify target bugs, guidelines place emphasis on the duration of time in hospital prior to the onset of infection. The longer the time in hospital, the greater the likelihood of colonization. There are risk factors for infection with more difficult-to-treat organisms, such as Pseudomonas, MRSA, and ESBLs. These risk factors include recent hospital admissions, antibiotic use, immunosuppression, and known colonization with any of these organisms. Empiric therapy should target the core bugs and account for these risk factors. Combination therapy for Pseudomonas infections is common, but not supported by the literature. Only if you are worried about Pseudomonas or other multi-drug resistant organisms is it reasonable to start with empiric combination therapy. For most patients, a single antimicrobial is sufficient. Once you have a bug identified, or if cultures remain negative at 48 hours, narrow or target therapy for the remaining treatment. Our patient, AH, was admitted from home for 6 days, and she hasn't been on antibiotics during her admission. However, if she had been intubated since admission, she would be considered a VAP and at risk of infection with more difficult-to-treat bugs. 7 days of antibiotics should be sufficient to treat most cases of HAP and VAP. 14 days minimum is recommended to treat bacteremic Staph aureus pneumonia. Key messages: start antibiotics promptly. Target core bugs. Consider patient risk factors. Combination therapy should be tailored once culture results are available. and treat most patients for 7 days.
Application in physical therapy. With the help of the physical therapy, exercises from the lower extremity exercises were initiated to address the patient's lower extremity weakness, improving the patient's lower extremity strength will tend increase her independence with transfers and mobility.
Alright, okay, why don't you go ahead and can you try to move your ankles back and forth? Okay, try to hold it up right there. Hold it. Over here, hold it right there. Okay, try to bend this knee. Good. Bend it for you. Okay, try to kick this foot up into the air. Oh, good. A little bit. Okay, over here, try to bend this knee. Good. Okay. All right, ready to try to kick that foot up off the bed. Almost, good. Now push out in my hand, push. Good job. Okay. How about your arms? Can you lift your arms up? Up. Try to lift this hand up to right here. Good. And down. On your right one, can you try to lift it up?
She's 2 out of 5.
All right, well, we'll start tomorrow and get doing some exercise. And push. 1, good. Push. 2. 1 down. Bend the knees. And push hard. Push, 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 push. Good. 3. And push. Push. Excellent. 4.
5. Good. 6. Good.
3. Okay, put some weight on those toes.
Alrighty.
Where are you going?
Don't
We're
worry,
gonna go
come
forward.
with it.
Just don't panic. Try and bring that right leg forward.
Yeah, good.
Good.
So,
Exactly.
now the left. Right. You see how you're shifting your weight? That's all it is.
Straighten those knees out.
Yeah, bring your knees
Try and tighten it in
back.
here. You don't have to be scared. I got you. You're not going anywhere.
Okay.
He's got the chair, so hold on. Ready?
1, 2, 3.
Yeah, I thought.
2 and 3. Good. Good. Excellent. Come on down, bring your knees down. And push it up. Okay, that's too easy. All right, ready? Come on down. And push. A little better. Try to want to get to where it's just, where it feels like a challenging load. Come on down. And push.
That's a challenge.
That's it. Okay, it's going to bring it down. Right there. Okay, let's see if we can get 10 of them right there. One down. Ready? Push. Good. 1. Push.
Perfect.
2. 3. 4. Great job. Feel good? Not bad.
Forward. 1, 2, 3. Extend. There you go. Okay. Remember what I told you about leaning back? Try and lean forward. So slide those hands forward. Left leg forward. There you go. Okay.
I feel for all the world.
That's okay. Same thing. There you go.
Great job.
Try and straighten out your posture. There you go. Good. Okay, bring those hands back a little bit so you stand straight. Stand straighter. Tuck your bottom in. Try and bring the right leg just a little closer and just stand tall for me. There you go. Okay, you want to try and sit down?
Awesome.
One of these at home to work out my frustration.
Right? One more. You got him. Great job.
Here. Okay. 1, 2, 3. Now. There you go.
Okay.
Now let's push this along. I got you.
I don't want you to, the knees don't buckle.
Mm-hmm. There you go. Look up every now and then. You're doing great. Look up, Darren.
Good job.
Looking great. Looking great. You're walking with a walker. How's it feel? A little better than those parallel bars, huh?
Feel like I'm going sideways like a crab.
Nice and tall. Keep on trucking. You're doing great.
Hey,
Great job.
thank you.
All right, great.
Yeah.
Wow.
I told you I would be back walking in.
Yeah.
Really good. Remember that?
Based on
Yeah.
you, I am.
We were looking forward to it.
Yes.
Who's this? Come on here.
Okay.
Okay, well, I want to first thank all of you therapists. I mean, really, you're in my heart. I didn't think I was ever going to walk again, but following your direction, getting the encouragement, doing what you asked of me, it worked for me, and it'll work for anyone who will give in to that.
One day at a time.
Yeah, just put yourself out there full force, and you can recover. It's amazing.
Pros and cons. Pros. Effectively treat digestive system disorders such as constipation, colic, gas. Cons. The patient was also still having episodes of emesis from the viral gastroenteritis during the first 3 days of physical therapy, which contributed to minimal mobility with therapy. Issue applied in Ecuador. The prevalence of these causing diseases, acquired diarrhea, in children under 5 years is 21%, becoming a serious health problem for children within this age range. These were the data obtained in the report of the Demography and Maternal and Child Health Survey in Quito. Conclusion. Personal factors involved in this case included the patient's height, level of motivation, and her independent prior level of function. These personal factors were beneficial in the course of her rehabilitation, and she was always participating in therapy in order to regain her functioning independence to return to her prior roles and activities.